Good afternoon, everybody, and welcome to our weekly deep dive session. Fantastic to have you all here, and I'm particularly excited about the lectures or the talks that we're going to have today, because I've actually heard one of them and I know how great that was. So I am already looking forward on your behalf for the fact that it's going to be presented here at this forum. So just as a quick reminder to everybody to please put your name, surname, as well as your MP number in the chat box for CPD purposes. And if we don't have your email address, please add that as well. Also note that this is an open meeting, so you're welcome to invite anybody to come and join us. This is an opportunity to learn for primarily focused on trainees, although I'm sure all of the consultants that's been attending, we've really been learning a lot as well. So this has been fantastic to learn together and to get to know each other better all around the country. And today it is the privilege of University of Cape Town to present. And we actually have two consultants presenting this afternoon, both of whom I'm sure is well known to everybody, but I'm going to introduce them anyway. And the first is, of course, Dr. Cecile de Tooy, who is a senior consultant in clinical hematology at the University of Cape Town, who's been there for many years with very, very special skills in transplantation, and is a brilliant general clinical hematologist who I've learned a lot from. And what the two of us share in particular is a love for history and a love for art. And so Cecile always brings in fascinating history into her talks, and you will find this as a common thread that I will be motivating for throughout the year, is that we ask our guest speakers to bring in a little bit of history, because I think especially for the younger trainees, it's important to know where we came from, to understand why there was a need for change, why we had to move from one thing to the next. And for that reason, I'm sure you're going to really enjoy this talk. After Cecile has spoken on oral blood thinners, history and current perspective, Dr. Diana Olofse, senior consultant at hematopathology or hematology in the NHLS at UCT, will talk to us about the direct oral anticoagulants and the laboratory aspects of monitoring and measuring and everything related to that. So I think we're going to have a nice mix of history, of clinical medicine, of real practical day-to-day application, and the laboratory side, which is of course very important for general day-to-day practice, but also for exams. So without further ado, Cecile, welcome, and thank you very much for being willing to give this lecture again. This is by popular demand, so we look forward to listening to this. Over to you.
Thank you, Prof. No. Can you all hear me clearly?
Very well, loud and clear.
Okay. All right. So as was mentioned, my topic is going to deal with oral anticoagulants, and it's going to be in two parts. The first part is going to be the fascinating history of warfarin's development as the major oral anticoagulant. And in the second part, I'm going to talk about practical clinical issues around the DOAC use. This medieval painting shows a man with a very swollen leg, presumed to be a DVT, and we can see marks indicating that leeches were probably used to treat the DVT. We know that ironically, the hirudin produced by the leeches probably had an anticoagulant effect, and the treatment may actually have helped. But it is amazing to think that for the most part, till the late 1930s, the only actual treatment usually given to patients with any form of thrombosis was immobilization. This gives you an idea of the timeline of the development of anticoagulation. In the 1800s, there was quite a bit of understanding of thrombosis already, including Virchow's triad, and the substance heparin had already been discovered in 1916, but the first clinical use of heparin was only in 1939, and of coumarin derivatives from 1941 onwards. So let us start with the story of warfarin. It is a story of sweet clover, bleeding cattle, rats, and presidents. Now, this story started in the early 1900s in the northern prairie plains of the United States and Canada, where farmers started to feed their cattle sweet clover. Now, initially, it all went well, and in spite of its ironic bitter taste, the cattle consumed the sweet clover. But by the early 1920s, there was a tragedy. Cows in these prairie plains of Canada and the United States developed a significant bleeding tendency that decimated the herds. It was initially thought to be an infection. But by 1924, the Canadian vet Schofield had correctly identified that moldy spoiled sweet clover actually caused the bleeding. And the only suggested treatment was that farmers should purchase fresh sweet clover and feed that to the cows and transfuse those with a bad bleeding tendency with blood from healthy cows. This was mostly unaffordable to the poor farmers. In 1929, the North Dakota vet Roderick concurred with these findings and reported a decreased prothrombin in the cows. At that point, a specific causing agent had not been found. It's now time to introduce the main character of our story, Carl Link. Now, this agricultural research scientist was appointed to the lab at the Agricultural Experimental Station of the University of Wisconsin. And ironically, his aim was actually to develop sweet clover free of the chemical coumarin, which gave the sweet smell but a bitter taste. Now, when we hear the word coumarin, we all thought, but wasn't that the cause of the bleeding? But actually, the natural coumarins, as they were found in sweet clover, were not the cause of a bleeding tendency. And at that point in Link's lab, finding the bleeding agent was not one of their priorities. But this was soon to change. We now introduce our second character, Ed Carlson. Ed Carlson was a farmer in Wisconsin, and in 1933, his farm was very badly affected, and he suffered heavy losses when sweet clover disease broke out again. As with many farmers, he could not afford to purchase fresh clover or transfuse his cattle. And he decided to go to the experimental station to talk to the state vet to find if there was any other advice. Unfortunately, the day he arrived, there was a blizzard, station was closed, and only Link's lab was open where Link and one of his associates were busy working. So Carlson came to them and asked for advice. They couldn't help or give him any advice other than what Schofield had said, and he left a very unhappy man, leaving behind him the rather strange gift of 100 pounds moldy sweet clover, a milk churn full of unclottable blood, and a frozen dead cow. Meanwhile, on the other side of the world in Denmark, a bleeding disorder was found in chickens fed with an experimental feed prepared by extracting all sterols. And the chemical researcher Hendrik Dam proposed that this feed must lack a sterol which prevented bleeding. And he named this sterol vitamin K, the K for coagulation as it's spelled in Danish, and he was able to isolate the chemical compound. In the United States, Edward DOACs described the actual chemical structure of vitamin K, and these two were awarded the Nobel Prize for their efforts in 1943. Meanwhile, in Link's lab, Ed Carlson's call for help so inspired them that they decided to do research to find the bleeding agent. But it proved to be quite a difficult task. And only in 1939, Campbell, one of Link's associates, was able to isolate pure crystals of what was thought to be the hemorrhagic agent. And here we can see a photo as taken in Link's lab of the actual crystals. And it was interesting to find that the bleeding agent ended up being a very complex chemical derivative of coumarin that was formed in connection with in the moldy sweet clover due to chemicals released by the interaction with the aspergillus. He named this compound substance decumerol, and he was also rapidly able to show in animal studies that the sterol vitamin K was able to fully reverse the effect of the decumerol. So not only had they identified the hemorrhagic agent, they were also able to provide the farmers with a treatment. Lincoln and his associates were now able to synthetically produce decumerol, and they also worked on other compounds, manufacturing over 100 derivatives of coumarin with varying potency as anticoagulants. His paper was read with great interest by clinicians in 1941, and clinicians in the pharmaceutical industry requested permission for clinical studies using decumerol as an oral anticoagulant in humans. They studied it in venous thrombosis as well as myocardial infarcts. And there was some efficacy, but it was very problematic to get consistent prothrombin values, and the potency was also questionable even at that time. In 1945, Link suffered a health setback. What was initially thought to be a pneumonia was found to be tuberculosis, and he had to spend 6 months in a sanatorium where, as described in his own paper, he said he was bored out of his mind and started thinking of new research projects for his lab. And he came up with the idea that they should develop a perfect rat poison from one of the coumarin derivatives. They had already tried decumerol, and that was not very potent, so they turned to one of the more potent anticoagulant coumarin derivatives, and eventually they chose compound 42. All these compounds were patented by the Wisconsin Alumni Research Foundation. And on the next slide, I've given a little extract from Link's paper where, in his own words, he described how he named warfarin. As he said, the name warfarin was coined by me, combining the first is the Wisconsin Alumni Research Foundation with the ARIN from coumarin, and, as he said, became a household word. This slide shows the exhibit where, or exhibition where warfarin was first launched as this superior rat poison. The next slide is one of my favorites that I got in Google Images, and this depicts the actual advertisement that was run in the newspapers and magazines of its time, advertising warfarin as this superior new rat poison. In the meantime, decumerol was the only oral anticoagulant available in humans, and it proved to be really difficult to use and was thought initially not potent enough. It is extremely ironic that the success of warfarin as a rat poison actually prompted clinicians from New York and Wisconsin to ask for permission to trial warfarin in humans as an oral anticoagulant. There was also a much publicized suicide attempt with a warfarin overdose, which was successfully, in 1951, which was successfully treated with vitamin K, showing that this agent was potentially reversible. By 1953, clinical trials had clearly found that warfarin was a far superior anticoagulant to decumerol in human trials, and it became commercially available as an oral anticoagulant in 1954. It's also quite interesting that the true mode of action in relation to vitamin K, vitamin K epoxide, and the clotting factors was only described in 1978. The terminology is sometimes confusing with coumarins, coumarin, decumerol, and all of those. So just to state clearly, warfarin sodium was the true generic name. But one of the first trade names was Coumadin, and you'll find that many American physicians to this day say Coumadin when they mean warfarin. So if you come across the word Coumadin, it means warfarin. You may also see it in some of the images and cartoons that I show in the talk. For Link, the surprises had stopped. Yeah, His biggest surprise probably came in 1955 when a friend of his working at the Army Hospital in Denver, where the then President Eisenhower was treated for a myocardial infarct, let him know the president is getting one of your drugs. And obviously, he correctly guessed that the President of the United States was now on warfarin, which 5 years ago was marketed as a superior rat poison. As for many medication or anything gets a lot of publicity, the conspiracy theories also came. And in the case of warfarin, the conspiracy theory, which persists till this day, even among some reputable historians and forensic pathologists, is that Stalin was poisoned using warfarin. Stalin died after presenting with stroke symptoms and a GIT bleed. The post-mortem showed an intracranial bleed, which was attributed to his hypertension, but there was also significant bleeding in other organs, which caused some people to feel that he had a systemic bleeding tendency, and speculations abounded that it was due to warfarin poisoning, and these speculations persist till now. We are now 67 years on from the marketing of warfarin as an oral anticoagulant. We know its therapeutic, narrow therapeutic index, the very frustrating drug and diet interactions, the long half-life and the slow onset of action. And we have adjusted to it by having anticoagulation clinics, frequent monitoring, heparin overlap, and specific guidelines regarding warfarin reversal and the periprocedural use of the drug. It is certainly a difficult drug for the doctors who use it and for the patients, but the one advantage with warfarin is the years of experience and that we can measure what we do. But almost from the beginning, there was a quest to find the ideal oral anticoagulant, and we know what we would want. We'd want equal efficacy, maybe something that doesn't need to be monitored, doesn't need overlapping heparin, and predictable reversibility, easy perioperative management, etc. And we'd also like it to be affordable. So we really want a miracle drug. The pharmaceutical industry was always working on trying to develop new anticoagulants. And it was only by the late 1990s, 2000s, that they had now developed the direct thrombin inhibitors and anti-10A inhibitors, but the early ones all had to be administered parenterally, which is not what the market wanted. And they went on a quest to develop some new oral anticoagulants. Come 2010, 2011, enter the DOACs, or so-called novel oral anticoagulants, with their very long and difficult to pronounce names. We met the anti-10A inhibitor rivaroxaban or Xarelto, and Ligatran, Pradaxa, the direct thrombin inhibitor, and these were soon followed by other drugs like apixaban, edoxaban, betrixaban. We are now 10 years on, and these NOACs have lost their novelty, so they've just become DOACs. And we must now ask ourselves whether they were truly these ideal anticoagulants and whether there's any chance of them replacing warfarin in most indications. As we are well aware, even if I don't continue with this talk, they didn't prove to be ideal, even though they are good anticoagulants. What are the current registered indications? Non-valvular AF and thrombosis prevention in hip and knee replacements, which were the original indications. And that has been added the treatment of DVTs and pulmonary emboli and the prevention of recurrent DVTs and pulmonary emboli. And all these indications are provided, a lot of certain contraindications are excluded. Off-label uses are also happening, and two of the most common off-label uses is for the thrombosis treatment and prevention of thrombosis in cancer, as well as for HIT. Now, I look at a few situations where warfarin, where DOACs may soon replace warfarin, and where a registration might actually be imminent. The one where registration is most likely to happen soon is for the indication in cancer-associated thrombosis. A meta-analysis in 2020 involving 1,756 patients showed a decreased venous thromboembolism, but increase, unfortunately, in both major and minor bleeding comparing the DOACs to low molecular weight heparin. Overall, it resulted in similar mortality and long-term outcomes. There has been specific interest in apixaban in cancer patients, as 2 trials have shown an equal efficacy to molecular weight heparin and no increase in major bleeding. It is expected that some more of these treatment and prevention trials will mature in the next 2 years, and till then, a lot of off-label use is certain to continue, particularly of apixaban, and without a doubt, registration for this indication will happen soon. An interesting thing is the proposal by some cardiologists that one should think of DOACs as the anticoagulant for bioprosthetic valves. Now that sounds almost like a criminal offense if you think of the Realign trial, where the bigatran versus warfarin in mechanical heart valves had to be terminated early due to significant excess bleeding and thrombosis in the DOAC arm, which resulted, as you know, to the DOACs being contraindicated in both prosthetic valves and valvular AF. But in specifically the bioprosthetic valves, there has been renewed interest in this drug, which could be easier for the patients on long-term anticoagulation. And a recent study of edoxaban versus warfarin showed non-inferiority in all endpoints. However, there would be more evidence needed that the DOACs may have a place here. Another interesting one is to use the DOACs for HIT. In a sense, it is almost an unmet need, because in many countries, the drug registered for use in HIT is often an infrequently used anticoagulant with which a lot of people are not familiar. In the United States, only argatroban, an intravenous thrombin inhibitor, is registered for HIT. It's a drug that's complex to use, and there's very little experience with it. Like in South Africa, many other countries recommend fondaparinux for use, but a lot of off-label use of DOACs had happened, and an analysis was done of more than 100 patients treated, as were reported in case reports. And when these cases were analyzed, it was found that DOACs were successful in preventing recurrent thrombosis in 98% of cases, and that there was only bleeding complications in 3% of cases. These excellent results caused the American Society of Hematology to already add the DOACs to their guidelines for the treatment of HIT, favoring rivaroxaban, for which there is the most experience. DOACs, of course, are not registered for children yet, but it is good to know that trials are ongoing at the moment for the pediatric formulations. The outcomes of the trials provisionally is good, and these should soon be registered. And apart from the fact that children will then be able to use DOACs, it should also help to solve the problem in adults with low body mass. I'm now getting to the slide of what is currently considered to be contraindications to the DOAC use, and there is a long list of which you are all familiar, and I'll be dealing with some of them. The ones in red, like thrombophilia, cancer, prosthetic valves, children, and extremes of body weight, are situations where the outcomes of current phase 3 studies may remove these as actual contraindications. Would now like to touch on one of the most thorny issues in DOAC use, and that is the DOACs in antiphospholipid syndrome. There's always been concern about the use, but as you are aware, specific clinical trials and meta-analyses have shown that there are 2 groups of patients with antiphospholipid syndrome where there is significant recurrence of thrombosis on the DOACs, and those groups are the ones with triple positive antiphospholipid syndrome or patients with antiphospholipid syndrome who had arterial thrombosis. And in those 2 situations, DOACs are clearly contraindicated. But there is not enough evidence in the literature at this point to say that DOACs are absolutely contraindicated in all patients with antiphospholipid syndrome. However, the European Medicine Regulator and the FDA have now both listed antiphospholipid syndrome as a contraindication to DOACs, creating quite a bit of confusion as to what to do when a patient presents with venous thromboembolism. You certainly can't go and investigate every single patient for antiphospholipid syndrome before starting a DOAC, and you can't not give DOACs patients with venous thromboembolism. So at the moment, societies like ITH and others are grappling with specific guidelines to clearly indicate which groups of patients may require testing for antiphospholipid syndrome, as they may be deemed to be at a risk. But it is quite topical and it is quite difficult to address. DOACs in women. The initial trials in DOACs usually focused on non-valvular AF and prevention of thrombosis and joint replacements. So it's only from the time that venous thromboembolism became an indication that many younger women in their reproductive years started using DOACs, and certain issues had to be dealt with. DOACs in pregnancy, as with all new agents, teratogenicity is feared. Animal studies did indicate possible teratogenicity. DOACs do cross the placenta. The true risk is still, in a certain sense, uncertain. International Society of Thrombosis and Hemostasis is keeping a register for patients who fall pregnant on DOACs, and in their analysis of the early data, they had received 230 reports, but only in 137 cases the pregnancy outcomes were fully known. And in those situations, there were 39 terminations, 31 miscarriages, and 67 live births, of which there were abnormalities in 3 of the babies at birth, but none of these could be attributed to the teratogenicity of the DOACs. So looking at the current feelings of ISTH and others, the use of DOACs in pregnancy is clearly contraindicated, but overall risk of attributable abnormalities is currently thought to be as low as 4%, and it is felt that falling pregnant on a DOAC isn't really enough indication for a medical termination of pregnancy, but that the parents should be informed of all the risks and the fact that how low the risk is, and should then be allowed to, of course, make a decision if they want an elective termination. Not surprisingly, DOACs are contraindicated while breastfeeding. When DOACs started to be used more commonly in younger women, there was a surprise class effect of the direct 10A inhibitors, and that is that they cause very heavy menstrual bleeding. In a study comparing patients on rivaroxaban to patients on warfarin, it was found that 29% of patients on rivaroxaban and 15% of patients on warfarin had problematic heavy menstrual bleeding. But in the case of the DOACs, the bleeding was much more severe than reported in the warfarin. And thus far, the reason has not been clearly explained. There were thoughts around effects on the uterus. People even suggested maybe patients changed the contraception, etc. But that wouldn't make sense for it just to affect the 10A inhibitors. The management of these problems can include stopping the drug for a few days per month, or if it's a major problem, changing to another anticoagulant. It's interesting that the dabigatran actually causes a lower incidence of problematic menstrual bleeding than even warfarin. Now, the DOACs use in organ dysfunction, not surprisingly with any drug that is metabolized either renally or by the liver or both, there has to be caution for the use in patients with organ dysfunction. And in this table, if you look at the last column, you can see the adjustments for the DOACs. We can see that for the dabigatran, the creatinine clearance has to be 60 or higher. Otherwise, the dabigatran becomes contraindicated. but a creatinine clearance between 30 and 59, you can still use dose adjusted rivaroxaban, but below 30, rivaroxaban and dabigatran become contraindicated. Apixaban, which is virtually wholly hepatically eliminated, can actually be used with caution in patients with lower creatinine clearance. Anticoagulating patients with severe liver dysfunction is obviously really problematic, and in severe cases, if it is needed, only low molecular weight heparin can really be considered safe. But there have been tables where you can look up the DOAC possibilities of using DOACs in relation to Child-Pugh classification of the patient with liver disease, and we can see Child-Pugh A dose reductions is required, and you can use any of the DOACs. But once you get Child-Pugh B, rivaroxaban and betrixaban are already contraindicated, and for Child-Pugh C, most of the drugs are then contraindicated. Drug interactions with the DOACs. This was, of course, one of the things we hoped would be minimal for the DOAC as a so-called ideal anticoagulant. There are not as many drug interactions as with warfarin, but they are still substantial, can be problematic, can be life-threatening. The groups of interactions to consider before starting the DOAC can be divided in agents that may affect the renal clearance, agents that affect the hepatic clearance, and agents that can actually give a concurrent effect on hemostasis or bleeding risk. Now, the ones that can affect renal clearance is drugs that can actually impair the patient's renal function over a period of time, and include drugs like non-steroidals, ACE inhibitors, and calcineurin inhibitors. You don't need to adjust the DOAC. You need to require, if the patient continues on these drugs, to closely monitor the renal function. And if at all possible, it's probably best to avoid using these drugs and using alternatives if you can. Agents affecting hepatic clearance. Now, these DOACs can be eliminated by either the CYP metabolic enzymes or the PG transporters, and depending on the extent to which these enzyme systems are responsible for DOAC metabolism, inhibitors or inducers of these systems can affect the DOAC action, with risk obviously of bleeding or thrombosis. And apixaban is virtually exclusively hepatically eliminated inhibitors of the CYP3A4 system can be quite problematic. But overall, what one should realize is that patients who have multiple comorbidities or have a condition requiring multiple agents should probably rather avoid taking a DOAC. And examples include HIV patients on antiretroviral drugs, patients post-organ transplant or bone marrow transplantation, patients with epilepsy, and patients with tuberculosis on rifampicin. Now, thinking of South Africa's burden of disease, that excludes quite a significant group of patients from DOACs, or you actually, even if it doesn't necessarily exclude them, have to think very carefully whether you would want change anti-TB or ARV regimen just to keep them on a DOAC, or you would rather give them an alternative anticoagulant. Not going to go into these complex tables, but you can get tables where you can read off which enzyme system is important in which DOAC, how it is affected, and what the dose recommendations are regarding drugs. There are also lists of drugs that are particularly strong inhibitors of the various enzyme systems. And we can see drugs that we may commonly use, like cyclosporin and rifampicin, certainly feature prominently, and also some of the ARVs. Drugs that can increase the bleeding risk. Now, the one group is antiplatelet drugs. If you're already anticoagulating and you're now adding an antiplatelet drug, you will always increase your bleeding risk. So try to avoid antiplatelet agents together with DOACs. And the other group is corticosteroids. We know that DOACs can particularly be problematic sometimes with GIT bleeding, and adding corticosteroids may make this even worse. So it's best to avoid these combinations, or at least cover the patients with drugs, including proton pump inhibitors, if you have to combine them. DOACs at extreme body weight. I've already mentioned that the problems with adults with low body weights might be solved as soon as the pediatric formulations are approved. This schematic representation shows how one should approach patients at extreme body weights. The interesting thing is that at the moment, till we have the pediatric formulations, any adult with a body weight below 60 kilograms, you need to rethink your DOAC use, and you might need to give adjusted doses of apixaban or rivaroxaban, and you should avoid the dabigatran, rivaroxaban, or betrixaban. On the other hand, where the body weight is above 120 kilograms, you can still cautiously use rivaroxaban and apixaban, but should avoid all the other agents. Now we get to one of the most thorny issues in the DOACs, and that is adherence to DOACs. Now, we're all aware of warfarin studies internationally and also in South Africa that generally INRs are therapeutic less than 60% of the time, and in some South African studies even less than that, less than 50% or worse. And there has been a hope that if you could get an oral anticoagulant that's easy to use, has less interactions with drugs and diet, and requires no monitoring, it might lead some patients to become more compliant, because warfarin is a nuisance, and if you can take the nuisance away, it might help. For DOACs to be effective, the adherence must be more than 80% at all times. Shockingly, at the moment in the literature and in a large meta-analysis looking at DOAC adherence in 500,000 patients, the adherence to DOACs is sitting at 65%. So we've shown that using a new drug which is not monitored, unfortunately, does not make people more compliant. There was one dabigatran study where in the long-term arm, only 40% of patients in a study were fully adherent by 2 years. In the Netherlands, where all patients get medicine from the state sector, they did a study about 4 years ago. There were 60,000 patients on the DOACs, and they just looked at the files and scripts to determine how many patients collect their medication. Only 70% collected the DOACs regularly. That's not even to say whether they actually took the medication. And in the European Union and in many other countries, DOAC non-adherence has been a major cost factor and actually a major waste of money, unfortunately. And we all know that with the advent of DOACs in many countries, the INR clinics became smaller. But what many centers now had to do is to use part of their INR clinic staff to run sort of clinics for DOAC adherence and DOAC follow-ups. There are even guidelines given for what needs to be looked at in these DOAC follow-up clinics, including the patient's health status, the adherence, the bleeding and thrombotic events, and also importantly to look at whether the patient's renal function and liver function is still stable, and concomitant medication. Now, I found an interesting paper from one of these DOAC clinics in Florida, which showed that in this clinic setup, the adherence was also only 66%, and they needed to do some sort of intervention for patients on DOACs in 71% of patient visits. All right. DOAC reversal. When DOACs first became available, that was one of the biggest concerns. And these drugs were sort of considered to be possibly irreversible, and if not irreversible, there was the concern that reversibility wasn't easily measured. And I think most of us would agree with Dr. Ratt that if we get called to the emergency unit for a patient who has to have an anticoagulant reversed at this time even, you would rather have to reverse warfarin, which we're all very familiar with. But in 10 years of use, there are now quite clear guidelines as to how to reverse the DOACs. Now, I hope you can see, I apologize for the colors that they put in this algorithm. It's not so easy. Basically, if you look at patients on a DOAC who are definitely bleeding, if the bleeding is mild and can be controlled simply by stopping the DOAC and other supportive measures, you don't need a specific reversal agent. But in cases of life-threatening bleeds or bleeds that cannot be controlled, a reversal agent is suggested. For the dabigatran, the specific reversal agent is idarucizumab. If it is available, it is very expensive. It is fast-acting and also quite long-acting. So a very good agent to use, but costly and not always available. Or you can use activated prothrombin complex concentrates. And then if a 10A inhibitor has to be specifically reversed, if available, andexanet alpha can be used. I'm not sure if it's ever been available in the South African context. It is registered in America and provisionally in Europe. Or otherwise, you can use the prothrombin complex concentrates, which we would know as factor 9 or hemosolvex. Patients who are not bleeding and who've had an overdose may also not need a specific reversal agent, and even trauma patients where there's no severe or life-threatening bleeds, you may not need it. But when you get to patients who need urgent invasive procedures, etc., or you cannot control bleeding again, you will have to use the reversal agents as suggested. Oh, sorry, it looks like it's frozen now. Sure. Okay. Right. In the next few slides, I just want to give you some notes from a Meet the Expert session at ER on the perioperative management of DOACs. Now, if it's emergency surgery, when a patient has just recently taken their DOAC, you look, if it's absolute emergency and you cannot delay, then there are certain measures that can be taken. If the DOAC was taken in the last 4 hours, one can even give the patient activated charcoal. There is the consideration to dialyze out the dabigatran, but you can obviously use the specific reversal agents. And there, as I said, for the dabigatran, idarucizumab, known to have an immediate effect. So you'll be able to go to theater immediately, unfortunately quite long acting, but may have a thrombosis risk. For rivaroxaban, you can try andexanet alpha, which has now been registered in the US, and there's some provisional registration in Europe. But unfortunately, it is very short acting, which may cause some problems with surgery, and there is a high risk of thrombosis. For us who don't have these agents available, the good news is that in general, using 4-factor prothrombin complex concentrates at 50 units per kilogram should fully reverse the bleeding problems caused by DOACs. Unfortunately, it is not easy to or possible at all sometimes to measure this in the laboratory. There was one study in Sweden where they just gave all patients 2,000 international units of the 4-factor PCCs across the board, and there was clinical proof of reversal in 74% of cases. All right, and then just as far as the perioperative, I'm not going to go into big details, but the major message here is don't stop DOACs too close to surgery. For rivaroxaban, 24 hours for minor and 48 for major for the dabigatran longer. And I will show you that one can find tables where you look up the bleeding risk of the surgery, the type of DOAC, and the creatinine clearance, and you can read off the time that you have to, when you have to stop the DOACs before surgery. The most important point on this slide is actually that it is not recommended when you stop your DOAC to bridge with heparin. There's been very high bleeding risks noted and no proof that it truly decreases thrombosis risk. There are also tables where one can clearly read off how soon one can restart DOACs, also depending on the bleeding risk of the specific surgical procedure. Now, I'm not going to discuss this quite busy slide in detail, but as you can see, there are clear-cut recommendations that one can follow, and you can find these tables where you go according to the bleeding risk of the surgery and the patient's creatinine clearance, and then you can read off how long before what surgery you should stop a specific DOAC. So the reality is that DOACs after 10 years are a very important addition to our anticoagulants. If we look at what they cost, for rivaroxaban, the current quote from Dischem is 1,100 rand per month for 20 milligrams a day. And in state, it costs just about half of that at 548 rand a month. DOACs can be used very successfully, but the success will depend on the doctor who initiates the treatment, because DOACs must be used for patients where it's indicated and where there are no significant contraindications. If you select the correct patient and the patient is highly motivated, the DOAC can truly be that ideal drug for that specific patient. It's also important to realize if somebody is on long-term DOAC use that laboratory monitoring may not be required, but to be safe, these patients do require regular clinical monitoring by somebody who has knowledge of DOACs to look at their concomitant meds, their general health, their renal function, liver functions, and so on. And of course, very importantly, their adherence. I also mentioned early on that there are phase 3 studies that may eventually lead to the approval of DOACs for other indications. But as we are now with DOACs, we can clearly see that DOACs will never be able to fully replace heparin or warfarin for all the current indications. This sheet from the King's College Anticoagulation Center in London clearly shows that for a lot of problematic situations in medicine and patients with comorbidities, warfarin still remains the anticoagulant of choice. So this brings us full circle back to warfarin, 67 years later. And this drug, in spite of the advent of DOACs, can still sometimes be the preferred option of choice in certain clinical situations. Thank you.
Thank you very much, Cecile. Sorry, I just want to quickly get this quiet here on my side. Thank you so much. That was a great talk on a very complicated topic. But I think the nice thing about this is when you listen to something as a story, and this is how human brains apparently have been designed. We remember things multifold times better. And I think this was a very good example of that. And thank you so much for preparing it in this way. It's hard work and a lot of effort, but I'm sure it's going to pay off greatly in the minds of everybody who are listening. So thank you so much for that. I'm going to, I don't see any questions right now. Can I just hear, are there any questions from the floor? If not, think about some questions for the end, but I'm going to hand over. Oh, before I hand over, I'm going to give Jacques Malherbe an opportunity. And can I just quickly check, well, before I give Jacques the microphone, Estelle, are you still in the room?
Yes, I am.
Estelle, I'm going to ask you to kindly, if you are available, chair the rest of the meeting, because I've just been called to a College of Medicine's meeting about the exams.
Oh, goodness.
So a little bit unexpected, but if you don't mind chairing the rest, and I'm going to let Jacques speak and hand over to you, and I'll be quiet from now on. So from my side, lovely afternoon, everybody, and thank you again, Cecile and Diana, for your contributions today. I'll have to look at the recording, Diana, to see your part later. Thanks, everyone.
Thanks, Cecile. I really enjoyed the talk. I missed the earlier part. I was on the phone, but I really enjoyed it. I just wanted for myself, in terms of the reversal of the DOACs, I always had in my mind that the preferred agent is the activated prothrombin complex concentrates such as FIBA, but I see now that there's actually data for the standard unactivated, as you mentioned, Hemosolvex. is there any sort of guidance as to which one is preferred, or is it in general just the standard prothrombin complex concentrate, Hemosolvex, or when would one use something like FIBA or the activated prothrombin complex concentrate?
In the DOAC guidelines that I found towards the end of last year, they seem to feel that maybe FIBA for the dabigatran and the prothrombin complex concentrates, the ordinary factor 9 for the 10A inhibitors, that they don't really specify why. I also have come across situations where they say rather use the unactivated because the FIBA has more of a thrombosis risk. So, I mean, those are things that one needs to think about. And the problem with using the factor 9 concentrate is that it's difficult to really prove laboratory-wise. I'm sure Diana will tell us about that, but how it works. But it certainly does work, and you see that study from Sweden where they just gave everybody 2,000 units of a Hemosolvex type of preparation, and in 74% there was clinical efficacy. I think the good thing is, if wherever you are, if you can get hold of 4-factor PCCs and somebody is really in trouble, giving them 50 units per kilogram should help. I mean, we'll at least know that, because we're not all going to be able to get adagrasizumab and probably not andexanet at all.
Thanks, Cecile. Yeah, that was interesting for me. And yeah, thanks again. Lovely talk.
Good afternoon, everybody. Estelle, may I continue?
Yeah, Diana. Thanks for showing that you're there. And I am, as everybody can hear, a little stunned to be chairing now. But I think this has been a very nice meeting, and thanks, Diana, to continue. And I think I can't say it better than Irma said it in her mail to everybody. An extremely useful lecture for both the old hands and the newbies in the field. So, great. Enjoy.
Right, thank you very much. Good afternoon, everybody. Just bear with me for a moment so I can transfer my slides over to the screen. Right, I hope you can see that. So for this second and fairly short tutorial, I'll be continuing then where Dr. Du Toit more or less ended, and we'll be taking you through a few pertinent lab aspects of the DOACs. So I've identified a few allos here on slide 2, and this is just to provide you with a tentative roadmap through the slides to follow. So before we look at the lab aspects of DOACs, let us just remind ourselves for a moment again what the characteristics of an ideal anticoagulant are. Many of these aspects have been realized to a great extent actually in the DOACs, but it's important to keep in mind how their characteristics inform lab testing. So the important features of an ideal anticoagulant would be oral and parenteral administration, no requirements for close coagulation monitoring and individual dose adjustments, a wide therapeutic window, appropriate elimination half-life, rapid onset, rapid offset, minimal interaction with food or other drugs, low non-specific plasma protein binding, and, if possible, ability to inhibit free and clot-bound coagulation factors. So now, if you look carefully at the scope of DOACs, of the DOAC FDA approval, well, then basically what we have here is a group of drugs of which the function is similar to that of warfarin and piheprins. But in view of their added benefits, there's potential here to replace the older drugs, at least in adults. The main agents currently available are presented in this slide. So you've already met the direct thrombin inhibitors. The dabigatran is the one that we know best. And then the rivaroxaban and the other three anti-10A inhibitors, being apixaban and doxaban and betrixaban. So unfortunately, I do not have local data to show you, but I can assure you that DOACs are being used more and more in South Africa as well. But here you can see statistics for an Australian-based use, well, basically Australian-based use of oral anticoagulants, specifically then Warfarin and the DOACs. And this data set starts in 1992. And you can see there that anticoagulant use has been in fact, on an ever-increasing slope over the last few decades. Note also the rapid increase in DOAC use since the introduction, with more or less a doubling of prescriptions since their more formal introduction in 2012. And note also that apixaban and rivaroxaban overtook warfarin already in that context in 2018, and furthermore that apixaban overtook rivaroxaban in 2019. The bigotrand use, as you can see, although still increasing, is dwarfed by the anti-10A agents. Warfarin use in this context continues to decline. Sorry. Right, if we look a bit closer now at the theoretical practical advantages of DOACs for the purpose of this discussion, it's specifically the predictable dose response and the wider therapeutic window that I'd like to highlight. And that really means fixed dose and relatively predictable kinetics with no dose adjustments. So translated a little bit further, these features are really what is at the essence of the so-called reduced need for monitoring aspect of DOACs. But it does not mean no monitoring or no measuring. And there are obviously a couple of shortcomings as well, aside from cost, which is really for us quite a big problem still in the public health sector. The fact that we cannot test is also a very real issue, that we cannot test by means of established methodologies that we are well acquainted with. So, monitoring and measuring of DOACs. There are some select pertinent circumstances where we still want to be able to test, and those include, for example, drug accumulation or overexposure in the context of renal or liver impairment, drug underexposure, and perhaps a VTE that has happened whilst on therapy, and one is wondering about compliance. You'll remember Dr. Dutoit talked about that in her tutorial. Then also, if one wants to determine if a DOAC is on board in an unconscious patient, the situation of a bleeding patient, to assess the contribution of a drug to this bleeding and to see if an antidote is needed, which is usually set at a reflex threshold of 50 nanograms per mol, to identify hitherto underdescribed drug interactions where one would want to check the effects of the on-therapy levels. In emergency situations where surgery is urgently needed, prior to high risk of bleeding surgery, where one has to decide whether antidote is needed, and that trigger level is set at about 30 nanograms per mol, extremes of weight, and also in some situations in the elderly. So basically, to understand DOAC effects on lab tests, you have to first have an idea of their various characteristics. For example, the bigotrand has low bioavailability and is at least 80% renal eliminated, and the others less so. And they all have relatively short Tmax, and the half-lives vary between 5 to 14 hours, etc. There's also some general patient considerations that have been highlighted by the International Council for Standardization in Hematology, the ICSH, including if non-emergent testing is necessary, there it's recommended that the trough drug level assessment needs to be done. The results needs to be provided in nanograms per ml, and also that the reported DOAC results should indicate that this particular lack of DOAC therapeutic ranges that we are aware of, but it is recommended to cite the expected trough levels correlating with dose from published studies. As you can see, this type of data is available in the table on this slide. So there's also a few important consensus recommendations regarding sampling. So the preferred specimen is plasma prepared from a 3.2% sodium citrate specimen, and this can be used for both quantitative and qualitative clot-based and chromogenic assays. For mass spec, serum or plasma can be used. Citrated samples should be processed within 4 hours. It's similar to some of our other coagulation tests. For dabigatran, if you cannot test the sample within 24 hours, it needs to be frozen, and 8 hours in the case of the anti-10A DOACs. Moving on to the actual laboratory testing then next. So the laboratory tests to consider in the context of DOACs include routine tests, specific assays, and then a couple of others. So let's start with routine tests. First of all, one has to keep in mind that these tests are not specific for DOACs and can be prolonged in many other situations. And DOACs themselves have rather variable effects on both routine and some of these specialized correct tests. They may give an indication of levels that may be high or low, but this is not necessarily linear with dose. In other words, they can provide a qualitative assessment of time to clot in some instances. But it's very important to note that both the PT and the APTT may yield false negative results, despite the presence of a DOAC being present in a concentration that could impair hemostasis. So this is especially true of the APTT in the case of dabigatran and the PT for the direct 10A anticoagulants. And therefore it's not sufficient, these tests are not sufficiently accurate to exclude potentially clinically relevant plasma drug concentrations. And just to give you an example, up to 30% of patients on dabigatran levels of levels of more than 100 nanograms per ml will have a normal APTT. In contrast to this, however, the thrombin time is very sensitive to the presence of dabigatran, so much so that a normal thrombin time can, with a reasonable amount of certainty, exclude the presence of a clinically significant amount of dabigatran. Another important point to remember is that the performance of these characteristics may depend rather strongly on the sensitivity of the reagent involved. So then we have some specific assays for measurements, and I'm just going to mention some of the important ones. First, for the direct thrombin inhibitors, that's now dabigatran. These include the dilute thrombin time, which is a slight variation of the standard thrombin time, thrombin inhibition test, and the Ecurin clotting time. For the anti-10A inhibitors, one can use a anti-10A chromogenic assay with a drug-specific calibrator according to the drug present. And here we would then use a standard reference curve constructed from a drug-specific plasma calibrator, as mentioned before. Interesting enough, the dilute Russell-Viper test can also be used to provide an estimate of the intensity of anticoagulation with all the DOACs without specific calibrators, and can also identify subtherapeutic levels, but further studies are still needed to confirm their clinical utility in this particular setting. And finally, just to mention that liquid chromatography or tandem mass spec calibrated to a specific drug is really regarded as the gold standard method that we aspire to. Slide 15 just provides a very abbreviated summary of the use of routine and some of the specialized lab tests. So what you can see here is that INR and the PT is a no, and mostly a no. For dabigatran, the dilute thrombin time and ECT may be helpful. And then the anti-TNA assays, drug-specific, are useful for the 3 anti-TNA drugs and providing mainly quantitative data. But then just a few words now on point-of-care devices and global assays of coagulation. There are a number of these developing technologies in the context of DOACs. They may be useful really for their wide availability because of regards to flexibility where you can put them and also the range of potential operators. It includes also viscoelastic testing, TIG and ROTAM, and ACT. So these technologies appear to be useful in the context mostly of a known DOAC, where specific testing may be delayed or not available. They may be useful to assess the efficacy of reversal agents, but one problem that we still have to overcome is a lack of standardization. But there's also a couple of new POC instruments in development. Some of these are very interesting, and they're promising us new technologies by which to measure both heparins and DOAC. And one example is an instrument called the Clot Pro device. And then lastly, we come to the DOAC dipsticks, which you may or may not have heard of yet. And there's been a few publications on this emerging point-of-care test. It takes advantage of the fact, basically, that DOACs are excreted into urine, and some very much so. It's been designed to provide a result that indicates the presence or the absence of DOACs within 10 minutes, so really rather quick. And the test strip has 4 test pads, one that gives an indication of the amount of creatinine in the urine, in other words, a proxy for renal function. Then there is a test pad for urine color to assess potential interference. And then 2 test pads, one for factor Xa inhibitors, so apixaban, edoxaban, and rivaroxaban, and one for the thrombin inhibitor, dabigatran. The studies published so far suggest that this dipstick POC test can detect DOACs with really very high sensitivity, specificity, and accuracy. And the authors and investigators into some of these studies have even compared it to mass spec standard of results, in other words, the gold standard. So the idea is basically that the high negative and positive predictive value of the tests, perhaps similar to how we up to now have been using the D-dimers in the past and currently, and how this can be integrated into laboratory and clinical decision-making processes, and then in so doing may ultimately improve patient care. So NICE has shared their thoughts about this DOAC dipstick technology earlier this year by means of a medtech briefing, providing interesting arguments, pros and cons, and expert opinions. But ultimately, they summarized with some cautions, including that the key uncertainties around the evidence for this particular technology are that the evidence is limited in quantity and quality, and there is currently no evidence assessing the effect of the test on clinical decision-making and long-term clinical outcomes. So clearly more work may be needed before the DOAC dipstick will become commonplace, but it might. And finally, just to mention a publication that you may want to have a look at also, this is the 2021 update of the ICSH's recommendation for lab measurement of DOACs. It promises to provide some information on the FDA approval of betrixaban as well, clarity on the use of the specific DOAC reversal agent for apixaban and rivaroxaban in context of life-threatening or uncontrolled bleeding, andexanet alpha, and in addition, some pertinent patient population-specific considerations and updates in point-of-care testing and global, and also regards to global coagulation testing. So interesting and important publication indeed. And that really brings us then to the end of my talk. I've provided you with some references here. Many thanks for listening to us. I'm not sure if there are any questions. Estelle, perhaps you can help me out there.
Yes, thank you, Diana. That was great. Concise and to the point, point of care, to the point. I don't see questions in the chat box. Is there anybody who'd like to ask a question? I was thinking while you were talking, and I was wondering about, do you have stories from our local setting at Fortescue with point of care issues, in the surgery or around the hospital where you had interaction with doctors on DOACs? That was interesting. I don't know how much has been your exposure to us, because I must say in our setting we use it so little that we don't actually get the problems. I'm sure it's very, very different in private, and I'm sure our colleagues that may be on the call that are in private labs are going to have lots of stories to tell.
Yes, Estelle, indeed, I was reminiscing about some years ago when I was still doing quite a lot of Warfarin prescriptions. And so I would say that my own experience with DOACs is really limited to really wishing at that time that it was really available. And since then, it's become quite easily available in the private sector, but we have very little interaction with it. So I've had one or two questions occasionally asked regards to mostly surgical type of scenarios, but other than that, I'm afraid in the public sector we yet have to catch up a little bit, and perhaps some of the audience who have more experience of this would like to weigh in at this point.
Okay. Oh, I see. Yeah. Okay. Okay, great. I just wondered, is there anybody in the meeting that wants to give some input from lab DOAC interactions? Is there anything specific? I can see that there's a message that was sent to me from Lina Sewanya, but I don't think it was specifically actually meant for me. But it was the upper limit for PCC that may be given for reversal of DOAC. And I think that is probably something actually directed at Cecile. I'm not quite sure if that's something that's still an issue that we need to discuss.
Well, I can just say that the recommendations in the guidelines I saw for last year, they suggested 50 units per kilogram of the 4-factor PCCs. Don't recall them actually giving specifics regarding the FIBA doses. Yeah.
Good. Any other questions or contributions to the conversation? Okay. So then it remains for me to thank the two speakers. Thank you very much for your amazingly interesting talks on a topic that's very, very common and that we all get confronted with. On the topic of another common disease that or issue that we get confronted with, many of you will know that tomorrow evening at 6 there will be a CLL talk, which will be done by some of our colleagues in private and also Charlene Parashnat. So remember to, if you want to know more about CLL, another very common encounter, think of that talk tomorrow. And then...
Sorry, Estelle and Charlene, sorry, on the 2nd, huh? It's on Wednesday.
Oh my goodness, I think it's the first today. For some reason I've skipped a day. Oh my goodness. It's Wednesday. It happens when you don't know if the month has 30 or 31 days. Anyway, and then we will obviously communicate with you regarding next week. I think there's been some exams in the PATH lab in this time, or is the exams are coming up next week? Am I wrong or right? Is there not some?
It's this week, Estelle.
This week. Okay, sorry, I didn't hear that. So, so it's still ongoing.
Yes, it is. I think they start on Wednesday.
Okay, then a hearty, you know, wishing success to everybody. So, okay, good afternoon and goodbye.